a biopsy or genetic testing. So we already mentioned the CK can be very elevated in people with myopathies or myositis. In people with very profound muscle wasting diseases like steroid use, chronic alcohol use, even hyperthyroidism, it can actually be low. And we said that CKs can be somewhat elevated in non-muscle diseases like motor neuron disease, GBS, and the like. But if it's more than 5, 7 times normal, it's probably related to muscle. Now, obviously, CPK can be elevated in trauma, right? People who have had a building fall on top of them with strenuous exercise, like a marathon, even after an EMG study. So you never check a CK after somebody's had an EMG because it will be transiently elevated because you're poking somebody with a needle, right, in many muscles. And we already mentioned race and sex affect CPK because CPK is an indicator of overall muscle mass. So as I was discussing with my student group a few days ago, right, that typically women have less upper body strength than men, typically. So usually the CKs will be lower, but that's not always 100% true. And then for reasons we don't understand, African Americans have higher mean CKs than non-African Americans. So if a healthy 23-year-old African American guy has a CK of 800, 4 times normal, I don't necessarily blink at that. Now, obviously, if he's weak or he's got myalgias or other symptoms, clearly that means something else. Other labs that we would get is you always want to check a GGT, because remember, AST and ALT are also in myocytes, not just in hepatocytes. So we have kids with muscular dystrophies, they have abdominal pain, somebody checked an AST, ALT, it's super elevated. They go, oh my God, they do a whole liver workup, right? God help us, some of them even get biopsies, nothing, of course. And then somebody decides to check a CK, and of course it's 10,000. So if you have a GGT, that will be normal if it's a myopathy. And then, you know, things like lactate, pyruvate, carnitine, that's usually more for things like a metabolic myopathy, not for a classic myositis. And we've already mentioned thyroid disease as a cause of myopathy. So obviously you'll check that. People with hyperparathyroidism can also get a myopathy. Obviously HIV can cause a myopathy. And these in cortisol, obviously hypercortisolism can cause a myopathy. So these are things you may or may not check. And then ESR, CRP can even be normal in a myositis. So the presence or lack of an elevated ESR doesn't necessarily mean anything. Now, we've mentioned muscle biopsies, that we used to do this before genetic testing. And again, we occasionally will still do those. And again, you want to biopsy a muscle that's weak, but not a muscle that's too weak. Because a muscle that's too weak, you're just going to see atrophic fibers and fibrous tissue, and you won't get anything meaningful. And again, you don't want to biopsy a muscle that just had an EMG done to it because you've been damaging it with the EMG needle. And again, in people with rhabdo, people with acute muscle damage, you don't want to get an EMG because you're just going to see mush. So again, we always argue with rheumatology about that because they're always recommending a muscle biopsy in somebody with the CK of 120,000 with acute rhabdo, and just going to be completely useless. And again, these are usually the muscles that we biopsy, the deltoid in the biceps in the arm, or the vastus in the legs, because we want to check a proximal muscle. And then usually we'll do biochemistry, immune staining, light and electron microscopy to look at the biopsy. And this is just an example of different myopathic abnormalities you might see. So you could see degenerating and regenerating fibers and ongoing muscle damage. You could do what we call central nuclei. Nuclei are usually on the edge of the cell, not inside. If it's in the middle, we see that in myotonic dystrophy. Obviously, if somebody has myotonic dystrophy, don't do a muscle biopsy, get the genetics. If you have, we're going to discuss poly and dermatomyositis in a few minutes. So if it's polymyositis, you're going to see mononuclear cells in the endomysium. If it's dermatomyositis, you're going to see inflammatory cells in the perimysium and in the walls of the blood vessels. You also may see atrophy in the perifascicular space for the dermatomyositis. If somebody has inclusion body myositis, which we'll discuss, you're going to see amyloid depositions in inclusion bodies, which is why we call it inclusion body myositis. So but muscle biopsy plays a role mainly for myositis diagnosis these days, but not much more. And then things that have come along a huge way before I was a resident, and now since I've been in attending, is I'm going to show you a picture in a few slides of MRI. And MRI is useful because it will show you the atrophy, But it's also very useful because if somebody has a myositis, you will actually see increased signal. So you'll see a hyperintense signal on T2 or on what we call STIR sequences, short tau inversion recovery. And that will be the site of where the muscle is swollen, where it's inflamed, and you could see that. So it also helps us select a muscle for biopsy, because if you have a muscle that's inflamed, that's the muscle you probably want to biopsy for a myositis. Now, people have also been using other modalities like ultrasounds. We don't really do that. I've been, playing around a little bit with it. The benefit of an ultrasound is you'll see a difference in the echogenicity, which will correspond to change in the muscle, like in a myopathy. And we actually can use that to show changes over time in a congenital myopathy or muscular dystrophy. The benefits are it's painless. You don't have to go in a machine. It's much cheaper. The downsides is operator dependent. But for example, in a kid, right, you can't just keep shoving them in an MRI scanner every 6 months. If you want to track progression of their muscular dystrophy, ultrasound, you can do it by the bedside. So people will sometimes do that. And then finally, we do EMGs. So this is an EMG. Sorry, it's a little hard to make out the motor units. These are very small motor units. If you see, when you put an EMG needle in a muscle, if you see very small, very thin motor units, so motor units are supposed to be twice as tall and twice as thick. This is a very thin motor unit right there, right where the cursor is. That's classic for a myopathy. Because in a myopathy, the motor units are still intact. They're just much smaller because you've lost muscle. So if you're trying to assess for the presence of a myopathy, you could do nerve conduction EMG testing. Nerve conductions will be normal because the nerve is normal. But like I said, on the EMG, you will see these very small, very narrow motor units. So this is an example of one here. Now I'm going to try to play a video. Let me maybe stop the sharing. And then let me see if this video will work. Okay, let's try this. So this is an example of what's called spontaneous activity. Spontaneous activity is when the muscle fiber fires spontaneously, when it's not supposed to. So at rest, the muscle fibers aren't supposed to fire spontaneously. This you will see in two different processes. If you have an acute neurogenic process, like an active denervation in a neuropathy, or if you have a myositis, an inflammatory myopathy. So let me see if this can share. Okay, let's try this. Okay, hopefully this will work. First, I'm going to play it for everybody in the room. You hear that bump? And these are all spontaneous units. Now let me try to share it. I don't know if this is going to work. Yeah, no, that's going back to that. One sec. Okay, here we go. Okay. Can you hear that, Dima? Not really? Okay, sorry. I was making it as loud as I can. The guys here can tell you it's pretty loud. It's like fireworks, exactly. But the other thing is these are these are what we call positive sharp waves. You see there's a positive deflection, positive sharp wave, and these are what we call fibrillations. They're very small. So each of these is probably 100 microvolts. So this is very, very small because it's just a muscle fiber, just a muscle fiber. So if you see this, this could be an active denervation, or it can be in a myositis, an inflammatory myopathy. You will see this as well. Okay, so these are what we call spontaneous activity. So positive sharp waves, fibrillations mean the same thing, There's no difference between them. So that's that. And then let me show you guys an example of a myopathy. Yeah. Oh. Yeah. Okay. Let me go through this. Okay. Let's try this now. Okay. I'm sorry, 1 second. So these units over here, and I'm going to show this for everybody else in a minute. These units over here are very small compared to, you see these units over here? So where it's very small units, very narrow, you see the narrow here compared to over here for the waveform. So these are classic myopathic units over here. These are normal motor units. This is a normal motor unit. This is a myopathic unit. So let me now share it. Yeah. Okay. I'm going to play it. I don't know if you'll hear it, but I'll show it to you. Okay. And now we're going to stop. So this is a normal motor units. Okay. This is probably 3 divisions. And then you see how small this is compared to that? That's a myopathic unit. That's less than 1 division. That's about less than 1 millivolts. You also see that this is wider than this over here. Another example, you see this and you see this. This is very small, large. So this is a classic myopathic unit, and it's also very narrow. Anything that's less than 1 division, this is about 1 division. Anything that's less than half of that is very narrow. So if you see this, this is a myopathy till proven otherwise. Okay, now, normally the whole screen should be filled up because you don't lose any motor units. So unlike a neuropathy, a neurogenic process, where you have gaps, you have big gaps in the screen, over here, the whole screen should fill up in a myopathy because you haven't lost any motor units. Your motor neuron, your axon, even the muscle's still there, there's just less muscle. So you haven't lost any motor units, but they're very small. So if you hear that, and there's a certain sound to it, so I'm going to play it one more time. There's that sound, that's a classic myopathic sounds and appearance. So you can diagnose the myopathy from an EMG, you just can't diagnose the etiology, obviously. It won't tell you that. So we've already mentioned doing different genetic tests if you think it's an inherited process, okay? So again, you could do a biopsy, you could do lab testing, you could do EMG, right? These are your options, and even MRI imaging. So shifting gears. So one of the classic types of myopathy is a myositis. A myositis is an inflammatory myopathy or a myositis. It means the same thing. So these are the possibilities. It could be idiopathic or it could be secondary. So if you're a rheumatologist, you'll see the bottom more than the top. If you're a neurologist, you'll see the top more than the bottom. So there's poly, there's dermato, there's inclusion by myositis. Okay. So what's a polymyositis? So a polymyositis is a cell-mediated process, okay? It's not humoral, cell-mediated. There's CD8 cells that are in the muscle fascicle, and there's endomysial inflammation. So over here, you can see on the polymyositis, there's endomysial inflammation in the endomysial space over here. On the other hand, in dermatomyositis, you get inflammatory cells that are around the muscle fascicle, or what we call perifascicular, between muscle fibers. And then you also see them over here, over here around the blood vessel wall itself. It infiltrates, these inflammatory cells infiltrate the wall of the blood vessel. They're perivascular infiltrates. This is an endomysial inflammation over here. So this is CD8. Dermatomyositis is more CD4 cells, B cells, CD4 cells. It's a humoral response. Okay, now obviously this is an inflammatory process. You're going to get tons of cytokines, TNF alpha, IL-1, right? That goes without saying. But in distinguishing between poly and dermatomyositis, again, you're talking about, are they CD8 or CD4? Are they, over here, are they endomysial? Or are they perimysial, perifascicular, perivascular? That's sort of what you're looking for. So again, endomysial over here. This is perivascular infiltrates over here. This is another example. Yes, Dima. Oh, sorry, Dima. I thought you raised your hands.
She was trying to say that we cannot see the slides.
Wait, sorry, Dima, I can't hear you.
No. Dr. Anziska, we can't see the slides. Could you please share the slides?
They can only see the virtual page?
Maybe the shared screen is still on the...
We can see the...
Is it?
Yeah.
Oh. Can you see it now?
Yes.
Okay, perfect.
Yeah.
Okay, I guess it was. So going back, so this is over here. So the polymyositis are endomysial, and then the perimysium and the perivascular infiltrates are dermatomyositis. These are CD8 cells. These are CD4 cells over here. Okay, and that's how you tell them apart. Now, this is an example of what's called a necrotizing myositis. So necrotizing myositis is frequently triggered by use of a statin, right? Anything that affects HMG coenzyme A reductase, right, affects that enzyme, can lead to an autoimmune necrotizing myopathy. And in this case, it's very dangerous because there's actual necrosis of the muscle. So over here, there's no muscle necrosis, right? You could see the muscle cells just fine. There's just a lot of inflammation. In a necrotizing process, in a necrotizing myopathy, it's the opposite. There's necrosis, but there's not much infiltration. So yeah, there's a little bit of infiltration here, but you see all here, you see these muscle cells are actively dying. Okay, various stages of necrosis. That's bad. You want them all to look like this, nice and pink, not like this. And the danger is if you don't treat it, you will lose the muscle fast because there's necrosis. So obviously that's extremely dangerous. So this is an MRI. So remember, he said before you can use an MRI to diagnose myopathy, especially myositis. So over here, you can see the hyperintense regions. Those are the muscles that are most affected by the myositis. And if you're going to biopsy it, this is where you biopsy, where the arrow is. Okay, so it tells you exactly where to go. So in this case, this is more of the anterior compartment, like the quadriceps at the hip level. So this is at the hip level. You know, for certain people, it may be certain muscles more than others. I already showed you guys the EMG. Again, these are just supposed to be very small Murdy units on the screen. And I've already shown you guys spontaneous activity. So that's for poly and dermatomyositis, right? So polymyositis, CD8, endomysium, dermatomyositis is CD4. It's the endomysium, perivascular atrophy, and perivascular infiltrates. Those both are treatable. You can treat those with steroids. We can use immunosuppressive therapy. You can even use things like rituximab. Those should be treatable. There are very, very few refractory poly and dermatomyositis or myositis. I don't know what the plural is. Have I seen a few cases of refractory myositis? Yes, but fortunately, they're very, very rare. You know, I had one unfortunate woman. She tried everything in the kitchen sink. We used prednisone, mycophenolate, azathioprine, methotrexate, IVIG, rituximab, TNF-alpha antagonists like Remicade or something, Plex, I think even, and she just continued to just lose muscle. And she actually died of dysphagia, and she just wasted away. So it happens, but luckily, probably less than 5%. So that's the good news. The bad news is inclusion binding myositis is not treatable. So inclusion binding myositis is a disease of older age. I will go out on a limb here and say you can never see it in somebody less than age 50. And I know 50 is not older age, but even 50 is very rare. You know, it's almost always even 60 and above. It's very rare. I don't know if it's really 1 to 8 per million, but it's very rare. And then I'm going to show you the inclusion bodies and rim vacuoles that you see on the biopsy. Even though it's an autoimmune disease, we have no idea what causes it. We have no idea what antibodies are involved. It begins very insidiously. So these patients, well, what would they complain of? They'll say, my legs are giving out because it develops with quadriceps weakness. And then eventually they'll come to a doctor and they'll have some quadriceps weakness and they won't know what it is. And it will slowly progress. These are the ones who also have the finger and wrist flexor weakness. So then they'll start dropping things because they can't hold them, because they're weak. So once you get that pattern of weakness, especially once you get finger flexor weakness, then you really want to think IBM. These patients eventually will start getting some facial weakness, but more bulbar weakness. And you actually can die of dysphagia if you don't have a feeding tube. And if they do progress to needing a wheelchair, but usually after 10, 20, even 30 years. So it's a long, long stretch. They almost never need ventilatory support, even though muscles are affected. The diaphragm just doesn't seem to be affected that much. And you saw me put this in bold, the finger, the forearm flexors. You need that. If you don't have that, you really should rethink your diagnosis of IBM. Okay. So this is an example of IBM. These are the rim vacuoles over here, and you could stain from them. These are depositions of amyloid. Now, I will tell you, for the residents in the room, not for the students. So for the students, close your ears. You can get rim vacuoles, not just an IBM. You can get rim vacuoles in polymyositis. When you send a biopsy, and the biopsy is like, yeah, we see, I don't know, CD8 infiltrates in the endomysium, and we see inclusion bodies. You don't go, crap, there's inclusion bodies. It can't be polymyositis. No, it can be. There's a little bit of overlap. You know, we teach you guys one is here and one is over here. That's not true in real life necessarily. Okay, now the students can listen again. So, but you know, in real life. And then this is basically showing which muscles are most affected. So you can see over here, the vastus and the lateralis and medialis are very atrophic. And you see the posterior compartments, you know, the hamstrings are very normal. Okay. So again, there's disproportionate atrophy of the quads. Don't ask me why. I don't know. You know, nobody knows. It's just one of those kind of questions. Okay. So that's IBM. So no treatment, very slowly progresses over decades. That's the fortunate thing. Dysphagia, finger, forearm flexor weakness, quadriceps weakness. Okay, so this is a very important slide because these are all of the different skin changes that you can see in dermatomyositis. Okay, and again, whether you're a medical student, a resident, a fellow, or an attending, it will show up on a test, I promise, at some points. So this is an example of Grotton's papules on the left side of the screen, right? You can see it's usually over the extensor surface. You can also get thickening as well, not just the rash, but also not just violaceous rash, but also thickening. It can also be over the eyelids. Okay. Now, it's much easier to see on fair-skinned people. On African-Americans or people with darker skin, it's more purplish. And then what happens is in people with darker skin, when the rash goes away, it actually becomes hypopigmented. I think I have a slide of that. Maybe not. I thought I did. No, I don't. Sorry. Thought I had a slide. So basically it becomes hypopigmented. So where the rash was, if you have dark skin, it's now hypopigmented. And I've seen this in a few kids who have had dermatomyositis. You know, you see it over their knuckles, over their, elbows, because it's now hypopigmented. Okay. This is Grotton's sign where it's thickened skin. Okay, in the region of the rash. Okay, this is the heliotrope rash. This is periungual hyperemia. It's almost like a swelling around your nail. Okay, so we also will see that in dermatomyositis. This is the shawl sign. So for those of you who like wearing shawls or scarves across your neck, that's where it is. This is a very classic example. You could see it also across the back. This is actually somebody with darker skin, and you can see that it's hypopigmented over here. That's probably somebody with chronic, dermatomyositis. Okay. You can see psoriform changes on the scalp. You can see calcinosis of the skin. So this is a pretty bad example of calcinosis popping out. It can actually pop out of the skin. It's pretty horrible. You can get a Raynaud's. This is a very extreme example. You can get what we call mechanic's hands or foot, where you see the thickening of the fingertip. So it's mechanic's hands because mechanics work with their hands a lot, so they get thick ends and callus. It almost looks like that. And then you could see it over here as well, this thickening over here, sort of almost like, it looks like a growth, if you're going to be a dermatologist, right? So you can't make a diagnosis solely based on the rash, but it will strongly suggest that diagnosis. And at the end of the day, you still want a muscle biopsy. Have we done cases of people with dermatomyositis? And we had one kid, and I can think of at least 2 adults. It was a rash, and we sent them to derm, and they did a skin biopsy, and it was inconclusive. And Dr. Geary sort of lost it, and rightfully so, because you should have done a muscle biopsy, And by the time they wanted to go back to do a muscle biopsy, they already put the kid on high-dose prednisone, which of course made it useless. So these are the conditions that are associated with inflammatory myopathies. So what are the ones that are going to kill you? Interstitial lung disease is definitely up there. So sometimes these people will actually go to a pulmonologist first, and you're thinking, my God, You know, if you had to pick one person on this earth to least diagnose a neurologic condition, right, it probably would be a pulmonologist. And I say this as a card-carrying internist who was thinking of going into pulmonary. You know, so they come to the office, they're like, I can't breathe, right? They do a CAT scan of the chest. They go, oh, you have interstitial lung disease. But nobody realizes you can't get out of the chair, right? They're actually gowering to get up, right? They're pushing off with their hands because, right, nobody in internal medicine actually does strength testing, right? It's FROM times 4 or whatever, right? And again, I mean, this can literally be very severe. I mean, you can require oxygen. It could be that bad, the interstitial lung disease. So that's one possibility. Another possibility is esophageal disease, where you get weakness of the upper third and or your oropharyngeal muscles, so you can't swallow and you aspirate, which is obviously bad. You can get cardiac disease. Now, frequently it's subclinical myocarditis, so it's not like raging myocarditis. Usually it's not like acute heart failure or severe heart failure. It's usually like, okay, we checked a troponin and it's elevated and everybody like loses their minds. But usually the echo's normal, the EF is normal, etc. And then for reasons, again, that nobody understands, you guys have all heard this, dermatomyositis, right? There's an increased risk of cancer. Now, what's the increased risk of cancer? I'm going to make it very clear. The increased risk of cancer depends on what your underlying cancer risk is. So for example, if you're a 60-year-old woman, you have to worry about, you know, breast cancer, maybe uterine cancer, those kind of things, right? If you're a 60-year-old man, you don't have to do a mammogram, obviously, right? So it's looking at what your overall risk would be, and it's just magnified across the board. So unlike other paraneoplastic diseases where you have a cancer and it causes something, this is just, it just increases your overall cancer risk. So the question that's always on the medicine boards, and I don't know if it's on the neurology boards, is what testing do you do? And the answer is, it depends on the patient's age and sex. So if they're a 50-year-old woman, it would be like a mammogram, maybe a colonoscopy or something like that. 50-year-old man, colonoscopy, etc. You know, prostate exam, whatever. That's what it is. It just increases your overall risk of cancer. Now, why dermato? Now, it doesn't seem to hold for poly or IBM. I don't know why. It just doesn't. Now, if you may have attendings, I think Dr. Perk, even for poly, will do a whole cancer screen, and there's nothing wrong with that, but the data hasn't been borne out like it has in dermatomyositis. Is that clear? Because that always comes up. So I already mentioned the risk with malignancy. Now, I will say certain cancers are a bit more common dermato also, like lymphoma, breast and lung, you know, ovarian carcinoma, but all cancer risks definitely can increase. So a lot of the time now, people have been moving away from using muscle biopsies to diagnose myositis, and especially the rheumatologists have been moving more toward using antibodies. We know this is an autoimmune disorder. We know that even though I said polymyositis is a cell-mediated response, right? CD8, et cetera, obviously the antibodies, the humoral system does play a role. And we know that autoantibodies are found in many inflammatory myopathies or myositis. And some people have argued that you don't even need a muscle biopsy. You can just make the diagnosis primarily from the serum autoantibodies. And if you order a myositis panel here across the street or at MyMo, and one of them comes back positive, you can theoretically make diagnosis without a muscle biopsy, which obviously, as you can imagine, is easier than cutting into somebody's muscle, taking out a chunk, and then sending it off to a pathologist. So these are myositis-specific autoantibodies. And then these are autoantibodies that are found in other rheumatologic conditions like lupus and Sjogren's and whatever else, okay? So these are some of the more common antibodies. And again, there's like 28 different antibodies, right? This is an example of all of the antibodies that are out there. You don't have to memorize every single one, but you want to memorize the ones that are either more common or associated with a very specific abnormality. So remember, I went on about pulmonologist interstitial lung disease. If you hear ILD and weakness, you think JO1 until proven otherwise, right? Hopefully everybody knew that. If you didn't, now you do. So JO1 is associated with interstitial lung disease, and usually it's a sign of a worse prognosis in polymyositis and also an incomplete response to treatments. So these are very bad polymyositis. SRP is another kind of myositis, and these patients usually have very severe, very aggressive disease. They can respond to treatment, but it's very aggressive kind of disease. And then MI2 is the one, and these are the ones who may have that, calcinosis. They have a lot of the dermatologic manifestations, this MI2, okay? And that's something to think about. And then this is one way of thinking about diseases in myositis. How do you separate them out? So you have, the ones that are associated just with skin, like MI2. You have ones that are associated with malignancy alone. That's the NXP2 and TIF. You have ones that are what we call anti-synthetase syndromes, mechanics hands, Raynaud's, arthritis. Then you think about that. You have the ones that are associated with the necrotizing myopathy. That's the HMG coenzyme reductase and the SRP. And the people with the SRP have a severe myopathy and very severe dysphagia. And then IBM, you see it's all alone, poor IBM. It's sort of in a corner. And this has the 5-NT1A autoantibodies. So again, it's a very different kind of disease. And then these are the overlap syndromes, RO-LA, with somebody who has a primary rheumatologic disease and then also has a myositis. So usually the myositis is secondary to the syndrome. So if you look at this slide, you see how we're grouping it based on the antibodies, not based on the phenotype, not based on the pattern of weakness or the other comorbidities. We're basically, those play a role, but we're basing it primarily on the antibodies themselves, and that's how they group them. So this is really, I would say, the future, even the presence of myositis. That's really what you should look for. Okay, so I hope that's clear. So the anti-synthetase syndrome over here with Raynaud's, arthritis, and mechanics hands. There's some overlap with lung disease like the JO1, people with the rheumatologic overlap syndrome with other rheumatologic disorders, people with the skin disease. All of these have skin disease. This one is primarily calcinosis. These have malignancy, IBM's by itself. And then this is the necrotizing myopathy, SRP, and HMG coenzyme reductase. So what are predictors of poor outcome for myositis? So one is if you wait too long, right? If you wait over 6 months and you're going to be like, why would you wait over 6 months? I will tell you, people don't always get an accurate diagnosis. We had a case of a kid with a myositis, and it took us like 9 months to get the biopsy. It was like everything that could go wrong went wrong. Now, thank God he didn't actually progress that much, but he could have. And people, if you wait too long, then you start losing muscle. You lose muscle, that's it. You don't get it back. Older patients do worse with myositis. Dysphagia patients do worse. If you come in with very severe weakness, that's a bad sign. If you've got ILD, cardiac involvement, and malignancy. Interestingly, CK doesn't seem to correspond to bad outcome. So if usually people with myositis have very high CKs because you have severe muscle inflammation and breakdown of the muscle membrane. But if your CK is 50,000, which is not unusual for a myositis, you're not necessarily that much worse than somebody with a CK of 10,000 in terms of prognosis. Same with sex and race. And then how do you treat myositis? So we've already mentioned using steroids. So steroids are very good because they work fast, right? Any second-line agent, methotrexate, azathioprine, could take anywhere from 3 to 12 months to work. So steroids work within 2-3 weeks at the latest. I've had patients within the first week already get better. Obviously, there's issues with chronic steroid use. Unless you're a rheumatologist, then you just don't care. And then what happens if you run into a resistant myositis? Right? Then you got to bring in the third-line agents, IVIG, or even things like rituximab. For people who have the cutaneous dermatomyositis, in other words, really just the rash, you can get away with hydroxychloroquine and just use sunscreen because they're very photosensitive. And you can even use topical immunosuppressants like tacrolimus or even oral cyclosporin. And like I mentioned, IBM, there's no therapy. People have tried IVIG. They've tried everything in the kitchen sink, and people swear by whatever, but there is literally no data for that. So I've already mentioned steroids for myositis. Now, you got to hit them hard, right? So this is the one thing the room guys and I agree on. You don't monkey around. We're talking about at least 1 mg per kg, and some people are bigger people. You're giving them 80 or 90 milligrams per day. That's a lot. And by the way, with kids, same thing. It's 1 mg per kg. That's life. And then some people have even used pulse steroids for really weak people with bad myositis who come in, and then they switch over to oral. I think that's reasonable. And then usually we do a mg per kg for a month, and then you start to taper. Now, again, we're talking about a very slow taper. We're talking about a taper over like 6 months to a year. And frequently when you start tapering it down, the disease roars back, and then you really need to put them on other agents and other immunosuppressive agents. So again, the azathioprine or methotrexate, you sometimes will start that together with the steroids, and that will then hopefully allow you to taper off the steroids and just rely solely on the steroid-sparing medication. Now, what happens if you start tapering down the steroids and the patient's like, I'm getting weaker again? Then you probably need to go back up on the steroids, okay? Their myositis is probably flaring back up, unfortunately, okay? Now, there's no consensus about how fast to taper them, right? So everybody has their own regimen. Here I gave one protocol. Usually when they get to about 20 milligrams, then they go much more slowly. People seem to be very dependent. Nobody knows why. Now, if you're starting to taper the steroids and then they get weak, there's two possibilities. Either the myositis is coming back, or maybe they've developed a steroid myopathy, right? Because we already mentioned that steroids can cause a non-inflammatory, non-painful myopathy. So then, of course, the question is how do you know which is which, right? You're tapering it down. The patient's like, I can't get up out of the chair. Is it the taper or is it the steroids? And there's a few ways of differentiating. So one is CK, right? We've already mentioned in a myositis, the overwhelming majority have elevated CKs, usually very high. In a steroid myopathy, over 50% have normal CKs. So if you check the CK and it's 100, which is normal, it's not the taper, it's the steroids. And then probably means you have to taper them faster or get them to a non-steroid treatment. But if you check a CK and it's 25,000, you got to undo the taper. You got to back off. You can also do an EMG. Remember I showed you guys spontaneous activity? If you have spontaneous activity, that's an inflammatory process by definition. That's a myositis. In a steroid myopathy, you do not see spontaneous activity. So if you do an EMG and there's spontaneous activity, you've tapered them too fast. And then you can also do an MRI. And again, if you see the bright signal, the hyperintense signal, that's a myositis. That's not a steroid myopathy. So in general, you should be able to differentiate between a steroid myopathy and a myositis. Yeah. Not usually. I mean, you could, but you don't usually have to because you have these other mechanisms by differentiating the two. So you don't usually have to do that, luckily, because you have enough to go by. And I will tell you, again, I can't explain why. I don't usually see, again, I'm going to jinx myself. I don't usually see steroid myopathies when we put them on treatment for a muscle disorder. I don't know why. Even in Duchenne, we don't see that either, right? And Robbie was with me yesterday in clinic. We had 2 Duchenne kids on steroids. Just don't get a steroid myopathy. I don't know why. It's usually like they're giving it for lupus and then they develop a steroid myopathy. I can't explain it. That's anecdotal. Don't quote me on that. We already mentioned the EMG, right? The spontaneous activity. And the other thing is with the spontaneous activity and the abnormalities that you see, frequently we don't just see them in the extremities, but we also see them in the paraspinal muscles. So your cervical, your thoracic, your lumbar, okay? And in fact, people with myositis can present with head drop because they have weakness of their cervical paraspinal muscles. So if you stick an EMG needle in your paraspinal muscle, which is not fun, you will see spontaneous activity and even myopathic units. And when you treat them with the steroids, spontaneous activity disappears. Now, the myopathic units may still persist. In other words, these small, narrow units, but the spontaneous activity will disappear because the muscle membrane is stabilizing. The overall damage is still there. That will take a much longer to restabilize. And again, this is just trying to show you, the spontaneous activity, these tiny little discharges, but you've already heard me play that. So I'm going to stop there. Any questions on myositis? Dermatopoly, IBM, the autoimmune necrotizing myopathy, or the necrotizing myopathy, any of those antisynthetase, just asking. Because they're going to ask you a question on this. They're going to ask you a question on this. They're going to ask you this. They're going to show you some skin process, right? Yes. So, exactly. Yes, even though we're looking at the slide where you're looking at the autoantibodies, I would say as a neurologist, as a muscle person, yes. But if you speak to a rheumatologist, they might not agree with that. Okay, so yeah, a few things. So one is the speed of onset. So myositis usually progress relatively rapidly. The degree of myalgia, so usually a lot more pain, sometimes cramping, but pain especially, muscle pain. Then you're thinking myositis. It can even be tender to touch, to palpation sometimes. Then you're really thinking myositis. If the CK is very elevated, and again, sure, Duchenne, you can have a very high CK, right? But if somebody comes in and they've had 2 months of progressive weakness, which is pretty fast, and the CK is 30,000, I would worry about a myositis. Now, if you're not sure, do the EMG, because if you see spontaneous activity in the presence of small myopathic units, that's pretty much got your answer. Then you'd probably do a biopsy. And worst comes worse, if you're not sure you biopsy and they go, it's a muscular dystrophy, you're like, okay, it's a muscular dystrophy, right? You know what I mean? But that's what you keep in mind. Or do the MRI. I've been doing a lot more of the MRIs, with the STIR sequence, because if you see what looks like inflammation, hyperintense signal, again, it's pretty consistent with the myositis. And we sometimes will track, some of you guys have been with me in clinic, we've had people with polydermatomyositis, and we're not sure, if it's burned out. So what happens if you don't treat the polydermatomyositis? Eventually, the muscle's inflamed, it becomes more atrophic, and then there's no inflammation left. So if you do an MRI and there's no inflammation left, it's burned out, right? There's no utility to giving a steroid because there's no inflammation left. So we've done that, and we've shown that on MRIs. That you used to see hyperintense signal, now you see no signal. And that means it's burned out. And there's unfortunately, no treatment at that point for a burned out myositis.
Thank you so much, Dr. Anziska. Can you hear me?
So we'll stop there. So tomorrow we're going to end with metabolic myopathies. I will try, if I can tonight, to send you guys an article from Muscle and Nerve on metabolic myopathy. So if anybody wants to skim it overnight, you're free to do that. I will try to send it out tonight. But we'll talk about the different metabolic myopathies tomorrow. Thanks, guys.
Hello, Dr. Anziska. Can you hear me? Dr. Anziska? Hello?
Okay.
Nope.